Hey everybody, welcome back to my channel. Today we're going to be taking a look at the elbow joint. Now the elbow joint's actually three joints that all join in a similar area. You have the humeroradial, the humeroulnar, and the radioulnar joint. But that's not what we wanted to get into today. Today we're going to be taking a look at examination techniques for elbow injuries. We're going to look at four things specifically. We're going to look at the palpation skills and some landmarks. We're going to look at the arthrokinematics, go over some joint glides and rolls for the various joints of the elbow. We're going to look at some special testing to assess orthopedic conditions and injuries, and we're going to take a look at a little bit of neurological testing to get an idea of what's going on. So without further ado, let's get into it. All right, so we're going to start off with palpation, looking at two structures primarily. We're going to look at the coronoid process of the ulna, and we're going to look at the radial head both medially and laterally. So first things first, got to straighten the arm out. Now the coronoid process is going to be the anterior bony prominence of the ulna. If you flex the arm, you find the humeroulnar joint in the crease of the antecubital fossa. You can feel a bony protuberance that should move underneath your thumb. It's going to be pretty deep down there. It's underneath muscles that can be a little bit uncomfortable or hard to feel on patients who are particularly muscular, like this one. But it is going to articulate with the coronoid fossa upon flexion and be a bony infield limiter to elbow flexion. So right there, I can feel it. Next, we'll take a look at the radial head. So the radial head also can be very difficult to feel on somebody with a bit more muscle mass like this one. But the radial head, the easiest way to find it is to rotate the forearm through pronation and supination, and you can feel it spin underneath your finger. So in this case, moving a little bit medial and then shifting the muscle mass over makes it easier to get to. And so you can feel it rotate you can feel the medial aspect rotate anteriorly here. The easier way to do it is to come the outside here and rotate into pronation and supination on the outside where you can be outside of the muscle belly. You can really feel it spin very clearly there. So that's the two primary palpation sites that we're looking at. And we're going to be talking about them in their rolls, glides, arthrokinematics, and function in just a second here. Okay, so now we're going to take a look at the arthrokinematics of the elbow joint and the various joints in it. We're going to start off by doing some distraction of the radius and the ulna. So with ulnar distraction, because of the curve of the olecranon behind, you want to scoop it away, kind of like an ice cream scoop. So getting the ulna in a loose pack position, which is going to be approximately 70 degrees, so come up to 90, drop down about 20 degrees, and in 10 degrees of supination, so just a smidge towards supination. You can use a golfer's grip on the proximal ulna. Golfer's grip is what we're going to be using mostly to hold on to these joints. You can stabilize proximally, feel with that index finger and middle finger on the opposite side. You can create a tractional force right here, distracting the joint while you palpate. And that's going to be a very good and efficiently directed force for the humeroulnar joint. Next, we're going to take a look at radial distraction. Radial distraction is again going to be a golfer's grip, but in kind of a different manner. In this case, just like you're playing putt-putt, you're going to take your fingers, your thumb, you're going to get a pinch down here on the distal radius. And so the radial loose pack position, radiohumeral loose pack position, is going to be full extension and supination. So I can have my fingers right in here, or even posteriorly, though you can't see them, on the radial head in the radiohumeral joint. And with a good pinch grip right there, a little bit of tractional force, you can feel it gently move distally or inferiorly. And this is going to be one of the best ways you can go about doing traction on, or distractional techniques on the humeroradial joint. Next, we'll take a look at and discuss the rolls and glides that are present in flexion and extension. First, we'll start with the ulnar humeral joint. So it being concave on a convex humerus surface. When we go into flexion, it's going to roll anterior superior and glide anterior superior. It's a concave surface, has the same roll and glide. And coming back into extension here, it is also going to roll inferior posterior and glide inferior posterior. Now, the terminology can be a little bit messy for these because of the different orientations present at different points in the motion. Though it may start out in maximal flexion, moving towards extension, it may start out moving a bit anterior. When it gets to about 90 degrees, it's going inferior. When it hits maybe 70 degrees, 60 degrees, past a 90-degree angle here, or 70 degrees shy of full extension, it's going to be moving more in a posterior direction. So the exact terminology is a little messy to describe the full arc of motion. But in general, it is rotating into extension around the end of the humerus. Next, we'll take a look at the radiohumeral joint, looking at flexion extension. So the radiohumeral joint, being biconcave in this case, is going to move pretty much exactly the same as far as rolls and glides for flexion extension. So going into flexion, the radiohumeral joint is going to roll anterior superior and glide anterior superior. Going into extension, it's going to roll inferior posterior and glide inferior posterior. So overall, radius, ulna, both acting similarly in terms of rolls and glides for extension and flexion. When things get a bit messy is when we start looking at the radio-ulnar joint in supination, and when we start looking at the ulnohumeral and radiohumeral joint in supination and pronation. So when we go to the radio-ulnar joint, it's going to move when we go into supination, the two aspects are going to approximate towards each other. So the radius is going to glide and roll medially, while the ulna does the opposite. And, well, it doesn't do exactly the opposite, but the direction of the glide is the same. The direction of the roll is opposite because it is a saddle joint, and it's going to be convex in that concave valley that is created in the end of the humerus there. And so when we look at going into supination, it's going to be anterior roll and a posterior glide. As it rolls anteriorly, it rolls into the skeletal structure of the ulna there, and it gets glided posteriorly. When it goes into supination, when you return into supination from pronation, it's going to be a posterior roll and anterior glide. So again, into pronation, anterior roll, posterior glide, into supination, posterior roll, anterior glide. Next, we'll take a look at a lateral glide of the elbow. So this can be done in a variety of positions. One of the issues that you run into with this is you have a conflicting set of joints here as far as loose packs go. So when you do joint play, you want to do it in the loose pack position. The radius loose pack position is full extension and supination, and that is the closed pack position of the ulna. So you run into a little bit of an issue as far as maximizing your joint mobility. So in the case of this, though the closed pack position of the radius is going to be 90 degrees, we're going to be doing our joint play in 70 degrees right here, as that's going to allow us to have one of the joints in its maximally loose pack position and one of the joints in not its closed pack position, which is about the best that we can do for this right now. So, of course, you want a good feeling hand, and we can start off with a medial glide getting a good firm grip on the structures, the radius and ulna, blocking with my hypothenar eminence here on the medial epicondyle and applying a good medial force, a nice straight forearm. Now a medial glide is going to facilitate pronation. The radius glides medially for pronation because it is biconcave. It's a saddled. The radius glides medially because it's biconcave, and the ulna is a saddle joint and convex for medial lateral movement. So the medial glide facilitates the lateral roll during pronation of the ulna there. When we do the opposite, when we do a medial glide, we can, or when we do a lateral glide, of course with a good feeling hand in here working, you ideally would step inside, but for the purposes of this video, I'm just going to line my arm up perpendicularly, get a good lateral force. This, of course, going to be doing exactly the opposite. A lateral glide is going to be emphasizing supination with medial lateral glides being performed, as I said, in the loose pack position. Yeah, so that's going to wrap it up for joint play for now. So next we're going to take a look at some special tests. We're going to start off with some tests for lateral epicondylitis, which is going to be pain, inflammation, and other complications coming from the lateral epicondyle here. So first we're going to do Cosen's test. It's going to be a pain provocation test, and it's going to look at maximally flexing the extensor carpi radialis longus and brevis. So to perform it, patient comfortably seated. You want them to be nice and relaxed. We're going to go ahead and bring her forearm a little bit closer to the end here. And so first steps first, you want to palpate the lateral epicondyle right here as the common tendinous insertion for the wrist extensor musculature. You're going to have the patient make a fist, and they're going to radially deviate their hand and extend their wrist. So just like that. Go ahead, hold that there. You're going to apply and so with a good stabilization and the ability to feel, you're going to go ahead and apply a flexion force to that. And what you're looking for is a pain at the lateral epicondyle. That's going to be a common theme for these tests, most of them being pain provocation tests for the lateral epicondyle. The next one that we're going to do is the Mills test. So it's also a test for lateral epicondylitis. It's looking at the exact opposite of the Cosen's test. It's looking at maximally flexing the lateral epicondylar muscles, specifically the extensor carpi radialis longus and brevis. So to perform it, again, patient seated comfortably. We're going to palpate the lateral epicondyle with it at 90 degrees. There we go. Keep the arm nice and stable. With maximal pronation, flexing the wrist and moving the elbow into full extension. So in this case, I'm actually going to move the arm off the table. You could also do this in standing. Flex the wrist, move the arm into full extension. And so you're looking for, again, a pain and provocation of the lateral epicondyle there, similar to the symptoms the patient's having. Next, we're going to take a look at a tennis elbow test, aka the Modley's test. The Modley's test is the last test for lateral epicondylitis that we'll look at. It stresses the extensor digitorum along with the extensor carpi radialis longus and brevis due to their positioning on the carpal bones, or on the metacarpal bones, metacarpals 2 and 3. And in this case, we're going to have the patient seated comfortably, nice and relaxed. They're going to stabilize the humerus, palpate the lateral epicondyle again with the forearm in full pronation. We're going to have the patient extend their fingers. And so I'm going to apply a flexion force to their fingers, so don't let me move your fingers. And you're looking for the reproduction of pain from the flexion motion or the flexion force that I'm applying on the fingers. You can be more specific for the extensor digitorum by doing individual fingers, or if you have a tenderness or a weakness that's more prevalent in the second and third metacarpal or digits, it can be indicative of a issue with the extensor carpi radialis, brevis, and longus, respectively, as they are maintaining the stability and the extension of those metacarpals. So Next, to move on to a new one, we're going to take a look at the golfer's elbow test. This is a test for medial epicondylitis. And we're going to be maximally stretching the muscles from the medial epicondyle this time. So to perform this, you can have the patient in standing or sitting. The important thing is that you have the arm clear and free to move. So in this case, I can just back this table up a little bit. I'm going to start at 90 degrees and while palpating the medial epicondyle of the arm, so right in here, we're going to supinate the forearm, extend the wrist. We can extend the fingers as well to be fully thorough with the structures. We're going to move the elbow into full extension. So this is another pain provocation test looking at pain at the medial elbow, reproduction of symptoms the patient may have had. Following that, we're going to take a look at a valgus stress test. Two different ones. We're going to take a look at the 30, 0, and 60 degree valgus stress test, just looking at different components of the medial collateral ligament. And then we'll also take a look at the moving valgus test. So to start off, we'll do in 0 degrees. It's a little bit easier in the lower extremity, just based on the nature of stabilization of the wrist and the firm motion that we can get out of this. It's pretty straightforward to apply a good force. Of course, you always want a feeling finger, but a good valgus force there. Next, we can look at 30 degrees, which still goes pretty well. You can see a little bit of joint laxity in this patient, and then coming up to 60 degrees. This is where it may get a little bit tricky because we can certainly get a lot more external rotation in this position. So you may need to move the patient more into abduction or try to use another block at the shoulder. Perhaps just bring the arm down close to the body. I'm gonna look at that. But you can again feel a good firm endpoint, and you should be able to feel and palpate the ligaments during this for their strain. Next, we're going to take a look at the moving valgus test, which is kind of a modification on this. You're going to bring the patient into external rotation, and you're going to apply a, which of course, if your patient has a shoulder pathology, anything like that, you want to be considerate of that, as this can be an uncomfortable position to be in as far as the glenohumeral joint goes. But we're going to palpate the medial structures while bringing the arm from 30 degrees up to 90 degrees, back down to 30, up to 90. Those are the ranges that you're looking in, testing the anterior MCL and the posterior MCL at different ranges throughout that. Anterior at 30, posterior at 90, where it really starts to kick in. So those are going to be our main MCL tests. Next, we're going to move into a real quick looking at biceps integrity. We have a cluster for that. It's going to be the hook test, the passive pronation test, and the biceps crease test, specifically the biceps crease interval test. So we'll start off with the hook test. The hook test is very straightforward. It's a palpation-based test. All you're going to do is you're going to come in, you're going to palpate the biceps tendon, and hooking over the biceps tendon, you should be able to pull your finger underneath it, almost like a fish hook, and feel that insertion going into the radial tuberosity down here. Ideally, you don't strum it like a guitar string, because that can be uncomfortable for your patient, and ideally you also have short nails, as that can be something also uncomfortable for your patient. But this is a very good test for ruling in or out full tears of the biceps head, as physically feeling it at its attachment and moving it, being able to hook underneath it and feel the prominence that it brings doesn't work if it's not attached. The next one that we're going to look at is the passive pronation test. And so the passive pronation test, you could also do it actively. You could do it with contraction. There's a lot of different ways you could do it, but in this case, we're going to do it passively. You're going to look at the muscle belly of the biceps brachii right in here, and we're going to look for its change in length moving from pronation to supination. And so, of course, when you move into pronation and the radial tuberosity is farther away, the biceps brachii is extended. When we move back, performing the primary action of the biceps brachii in bringing it into supination, we see that the muscle belly shortens. Depending on the patient, it may be more prominent than others, but in this case, this is a negative test as the hook test was also negative. The last thing that we're going to look at is the biceps crease interval test. And so the biceps crease interval test is done by, you palpate the muscular belly of the biceps brachii until you come down and you reach the musculotendinous junction. Right there. You're going to mark that with a pin, and then you're going to come down and find the crease of the antecubital fossa right through here, and you're going to mark, you're going to take a measurement device, tape measure, something like that, and you're going to measure the distance between the musculotendinous junction and the crease of the antecubital fossa. So 6 centimeters is going to be the norm for this specific test. Greater than that, especially notably greater than that, can be indicative of a biceps tendon distal full tear, as it would avulse proximally, giving you a Popeye's sign. Not necessarily a conventional Popeye sign like you see with a slap lesion, but a Popeye sign nonetheless. Those are going to be our 3 primary biceps tear tests that we're going to use. Okay, so next we're going to take a look at a pair of neurological tests, tendinocubital nerve test and a elbow flexion test. The first one we're going to look at is the tendial nerve. So you're going to come on in to the ulnar side, to the cubital fossa, right in here. You're going to apply a tap in the same location the tendial fossa is on the ulnar nerve. And so if the nerve is irritated, it's going to cause a reproduction of symptoms, either distally or locally. You want to tap 4 to 6 times. You don't need to tap particularly hard, but they want to be firm and concise taps. You don't want them to be sloppy or anything like that. And so that's going to be a good way to look at neurogenic issues that may be resulting from an entrapment there. The next one that we're going to look at is the elbow flexion test. So go ahead with your elbows at your side, flex your arms all the way up, and extend your wrists all the way. And so this is going to put a semi-maximal stretch for this position on the cubital fossa right in here, especially through that ulnar nerve. You want to have the patient hold this up to 90 seconds, looking for long-term reproduction of symptoms. And if they don't have reproduction symptoms here, but you still suspect, you can further this test by having the patient bring their arm up to 90 degrees in exactly the same position, a nice relaxed shoulder, nice extended wrist, nice flexed arm. And so holding that for another 90 seconds is going to be the next level, as that's going to further lengthen the course of the ulnar nerve down into the hand. If you wanted to bring this even maybe a little bit farther, you can stabilize the shoulder, raise the arm higher, and that's going to put an even greater stretch on it. But those are both positions for 90 seconds is the conventional thought to it, and both of those are going to be good for assessing whether you have any ulnar nerve issues that are going to be present with your patient.